Hello and welcome to Discovering True Health, your weekly deep dive into health and wellness. Thank you so much for joining us today. Please hit the subscribe button. It helps us out a lot and you'll stay up to date on all our upcoming shows. We also have a lot more great information on our website, Instagram, and Facebook. All those links are below. So today we'll be discussing the current opioid crisis that's happening in the US, and we'll specifically be talking about the synthetic opioid called fentanyl. We'll be learning why it's so readily available and addictive, the signs of an opioid overdose and what to do, and new effective treatments that help with addiction to get our health and wellness back and recover. Now, drug overdoses are now one of the leading causes of death for Americans under the age of 50. And recently, there's been a reemergence of trafficking, distribution, and abuse of illicitly produced fentanyl, which is a powerful synthetic opioid that's 80 to 100 times stronger than morphine. Now, China and Mexico are the primary source countries for fentanyl trafficked directly into the US. And synthetic opioids, including fentanyl, are now the fastest growing and most common drug category involved in drug overdose deaths in the US. They kill more than 136 Americans every day, and the national overdose death rate increased 255.74% between 2000 and 2019. Now, the other issue we're seeing is because of fentanyl's potency and low cost, drug dealers have been mixing fentanyl with other drugs, including heroin, methamphetamine, and cocaine. And this is especially risky when the users don't often know that the drugs they're taking contain fentanyl, which can be more than their bodies can handle and be more likely to overdose. So my guest today is Dr. Joseph Volpicelli. He's an addiction expert and executive director of the Institute of Addiction Medicine, which addresses the need to get evidence-based addiction treatments into clinical practice. And he is also founder of the Volpicelli Center, an intimate addiction recovery center that provides research-based recovery to fully support their patients in their recovery so they can get back to living fully. Dr. Volpicelli graduated from the University of Pennsylvania's prestigious medical scientist training program, and his research has led to many important discoveries in addiction treatment. So thank you, Doctor, so much for joining me today.
Thank you for having me, Christy.
Now, I'd love to start with hearing a bit about your journey and what inspired you to focus your research and on addiction treatment and open your addiction recovery center.
Sure. Yeah, I've always had an interest in the relationship between behavior and diseases. So while I was a medical student at Penn, I had a patient of mine who had a problem with alcohol addiction. And when I saw him, he was in severe withdrawal. And when I talked to him later, he described that while he was in Vietnam, he used opiates. But when he came to the United States, he finished his tour of duty, he no longer had craving for opiates, but rather he enjoyed drinking alcohol and he became addicted to alcohol. I was wondering how that occurred and what was the relationship between trauma and alcohol and opiates. At the time, I was doing research in the psychology department with rats, and I was trying to understand the relationship between stress and physical diseases and mood disorders and anxiety disorders in rats. And I decided to look at an animal model of drinking in rats. And what I found was that rats that experience uncontrollable trauma experience all the bad effects of stress. In one experiment, I found that rats who had uncontrollable stress had a higher rate of getting cancer. So I would inject cancer cells into rats, and I found that most of the rats who had uncontrollable stress wound up dying from the cancer cells. But rats who had the same stress, but they could control it, had much less high rates of death. And so it was the controllable factor that was important in terms of producing the bad effects of stress. And so I wanted to see if that had a factor in terms of alcohol drinking in my animals. And what I found was indeed the rats that had the uncontrollable trauma drank more alcohol than the rats that had controllable trauma or no trauma at all. One of the things I was surprised to find was that most of the alcohol drinking occurred after the stress, not during the stress. They came up with a model of how alcohol and opiates and stress all interact sort of the same way in the body by stimulating opiate receptors. So opiates do it directly, but alcohol can do it indirectly by stimulating the release of endogenous opiate molecule called endorphins. And it turns out stress can also stimulate the release of endorphins. And when your body gets used to having your endorphin system, your opiate receptor system stimulated, and then you suddenly turn it off, you have a rebound effect in which you experience craving for opiates, alcohol, or stress. And I reasoned that if you could block those opiate receptors with a medicine called naltrexone, you should be able to block post-stress drinking in rats. And indeed, I found that that was the case. I could do that. So I could block stress drinking in rats. Subsequently, I did the experiment in veterans and humans, where I gave humans either a placebo or naltrexone, and I found that I could dramatically reduce the chance of relapse in people who received the naltrexone. And the people on naltrexone, when they drank, they experienced no high from the alcohol. They didn't get any euphoria. And a lot of times, if they went to a bar and had something to drink, they would leave the drink right there at the bar because it was no longer pleasurable for them. And so we did the study, and other centers did similar studies, and we wound up getting naltrexone approved by the FDA to treat people with alcohol use disorder, with alcohol addiction. One of the things that we found was that while the medicine worked well, it worked well in people who took it consistently. And so very early on, I realized that if I was going to use a medicine to treat an addiction, it had to be combined with psychosocial care to help engage people in treatment, get them to stay in treatment and be adherent, and also address the other problems associated with their addiction. And so we designed a program, and we had a lot of success in terms of helping people recover.
Wow, fascinating. I have so many questions. So what is the difference? You talk about controlled trauma and non-controlled trauma. What's the difference between that?
Yeah, so in the study that we did with rats, and it's been replicated in many other species, including humans, if you can do something to turn off the stress, in the example for the rats, if they would run back and forth in the shuttle box, they felt much better, they felt more in control, and they were much less likely to get symptoms of anxiety, depression, and physical disorders, including being able to defend against cancer. And that's relative to rats who had no experience with shock at all. In fact, in one experiment, I found that the rats who had experience with controlling trauma turned out to be more gritty later when they were faced with trauma, even more gritty than rats who had no trauma at all. I called it learned mastery, that somehow that buffered them so that they were able to continue to try to escape, even when escape was very difficult. And if the task was very hard to learn, they had an easier time learning it. And so that dimension of being able to control things in your life turns out to be very important in terms of that stress response that I talked about. Wow.
So basically, childhood trauma or some sort of trauma that we incur in our lives that stimulates these receptors.
Mm-hmm.
And then once the trauma kind of, we're away from the trauma, those are stimulated. And then that's what makes us crave alcohol and opioids to kind of fill in that.
Yeah. So I've noticed that for many people, if I look at their pattern of drinking, that during the week when they're really stressed with a tough work schedule, they may not drink very much then, but maybe at the end of the day, the happy hour is when they're interested in drinking, or when the weekend comes, that's when they're really interested in drinking. So it helps explain why people tend to drink after trauma is over, but not necessarily before the trauma or during the trauma. Now, over time, when people become addicted to alcohol, they'll drink anytime. It doesn't have to be when the trauma is over, but at the early stages of addiction, it seems that when trauma is over, that's when they are really interested in drinking.
Because these receptors are stimulated, so they need to kind of.
Yeah. So what's important to keep in mind, and this is really important concept to look at addiction, is that when your receptors are stimulated, when there's something that makes you feel good, you don't stay feeling good. Your body adapts to it. And when that good thing is over, you have the opposite reaction where you feel bad. So things that give you euphoria, over time, you become tolerant to it, and it doesn't give you euphoria anymore. And that's true for opiates. It's true for even relationships sometimes. But when the relationship is over, when a person no longer has opiates to take, they go through a rebound phase in which they feel awful. They feel agony. And if you learn to go back to using your drug when you feel that agony, that's what creates that addictive cycle. And that's when one drink turns into 1,000 drinks, or one shot of heroin turns into multiple shots of heroin. And that creates that vicious addictive cycle. I think you had a guest on earlier that described it with food. He did a beautiful job of talking about his problem with corn chips.
Yes.
Or potato chips, I think it was.
They were the Pringles, I think? Or
yes,
no?
The Pringles.
Yeah.
Yes. I have a problem with these pretzels that have peanut butter inside. And when I start eating them, I have a really hard time controlling how much I eat. And so I have to hide them so I don't get at them. But for me, for that mini addiction, the withdrawal craving lasts about 20 minutes. So if I can distract myself, then I don't go back to eating those pretzels. And so that's an important concept when we think of addiction, that there's an effect of the drug itself, but then there's also an effect when the drug wears off. And often that effect is opposite to the effect of the drug per se, and creates the need, the motivation to use more of it. And that's the addictive cycle.
Right. And that also makes sense too with the link between childhood trauma and drug addiction as well.
Yes. So yes, you're exactly right, that many people who've experienced trauma when they were growing up develop a pattern that their body becomes sensitized to the trauma. And so when they're exposed to events, rather than look to ways to control it, their body responds by having a release in the fight or flight response or the endorphins. And even during the trauma, they may feel numb. They may not even experience the trauma, but when it wears off, they feel irritable, they feel upset. And if they discover alcohol or opiates, they can use those compounds to soothe themselves to deal with the trauma. And so that can be a huge risk factor for someone going on to becoming addicted later. And may have all the trauma that we've been going through over the past couple of years may be one of those reasons why fentanyl and opiate use has increased, and also why alcohol use has increased, that people are trying to cope with dealing with all the trauma, and particularly when they feel a little bit relief from the trauma, they feel awful and they need something to take that awfulness away. And so they will use drugs and alcohol.
Right. I mean, you've heard, in mainstream news right now, the whole Johnny Depp trial, and we've heard him say, he's got major childhood trauma, and we've heard him say he does it because he can't take the pain. So it's kind of this. That's
right. And no trauma is intermediate, but if you have trauma that you can cope with, that you learn to control and actually act sort of gives you some resistance so that you can deal with trauma later in life without giving up.
Right. And one more question on those lines. So rats actually drink alcohol, and do they get drunk?
They do, yes. Yeah. So when I did the research initially, they said that I couldn't get rats to drink alcohol, but I found that by giving rats an opportunity to recover from the stress, that's when they like the alcohol. And also that you can now breed rats that really love alcohol. So certain genetic strains really love alcohol.
Wow. Yeah, we just finished showing epigenetics and talking about how you can actually pass intergenerationally these types of traumas. That's fascinating. Okay, so let's get into fentanyl. How I had mentioned to you before we started filming that just in the last 2 months, I've had 2 neighbors tell me that a teenager in their family had overdosed on fentanyl. And this is a major crisis happening in the US. So let's kind of start with the basics. So what is fentanyl and how does it affect the brain and body?
Yeah, so fentanyl is a synthetic opioid. So it's a man-made compound, and it's incredibly potent. As you pointed out, it's between 80 and 100 times more potent than morphine. So a very small amount of it can be transported from Mexico or China. And there's huge demand for it in the United States right now. And what we find is that it's replacing heroin. So when I see patients now who sometimes they believe they're buying heroin on the street, when I check their urine, it actually has fentanyl in it. And so it's replaced heroin as the common drug that people are abusing on the street.
Wow, interesting. So why is this so readily available right now? And can fentanyl, I mean, it sounds like from what we just talked about, fentanyl use can lead to addiction. But why is it the leading cause of overdose deaths in the US right now?
Yes. So a few years ago, when I would see patients, most of the patients would have heroin in their urine. And so that was the leading cause of overdose deaths. But more recently, the fentanyl has replaced pretty much all the heroin. And so when people come in now, it's fentanyl. What makes fentanyl so dangerous, however, is that because it's very potent, people often don't realize the dose that they're taking. And as the story you described, virtually every family I know has been touched in some way who's had an overdose death. It's really a terrible problem in the United States right now. And you're absolutely right when you say 100,000 people, it's the leading cause of death for people under 50. It's a very terrible problem and a problem that I don't think we're doing a very good job of addressing. And I can talk to you about that a little bit, about how we can address that. But it's cheap. So it's easy for drug dealers to make money selling it. It's even replacing other illicit drugs. For example, I have a patient who believed he was buying Xanax on the street, and he showed me the pill, and it looked exactly like a Xanax tablet.
Wow.
But when I checked his urine, it was positive for fentanyl, not for benzodiazepines, not for Xanax. And so people are pressing pills to look exactly like Xanax, benzodiazepines, Adderall, and it actually has fentanyl in that. And so people are taking these drugs who are naive with respect to using opiates and accidentally overdosing and dying. So we see that as well. So besides addiction to fentanyl, we also see people who are dying accidentally because they're taking something that they think is a benzodiazepine and it turns out to have fentanyl in it.
Right. And especially children. I mean, a lot of these children are, experimenting, trying drugs, and they think, like you said, they think they're buying something and it's actually fentanyl, and they're taking a bigger dose than their body can handle.
Exactly.
A very concerning statistic I found stated that by 2015, Americans were consuming 80% of the world's oxycodone and opioid painkillers and 30% of all prescribed painkillers, even though Americans make up less than 5% of the world's population. So many, people are actually prescribed synthetic opioids. And for those people, what are some signs to kind of look out for in our prescription drugs when we may be using a synthetic opioid to know if it may be becoming an issue or an addiction?
Yeah, that's a great question. I actually did some research where I looked at claims data from insurance companies. And what I found is that among people who are prescribed opiates, about a third of them look like they're having problem with abusing the opioids or getting addicted to them. And what we found in the data was that people who started increasing their doses, so after they've been on opiates for a period of time, usually between 6 and 12 weeks, some percent of them would start to increase the dose that they were taking. So even though their condition usually was some chronic pain condition, they needed more and more of the opiate to get their pain relief. The people in the study then were also started doctor shopping. So we would find that they would get prescriptions from this doctor and that doctor. And so those are some of the signs. Now, if you have a loved one that you're concerned, I would look for things like that they need more and more of the opiate, that they get more and more concerned as their prescription begins to run out, that if they have periods where they look like they're going through opiate withdrawal, that's very important. So opiate withdrawal looks very much like someone who has the flu. So they might have the sniffles, they might have nausea, vomiting, diarrhea, muscle aches, chills. They feel absolutely awful. In addition to that, psychologically, they feel out of sorts. They feel anxious, panicky. It's a horrible state. And if they associate those symptoms with that they need more opiates, you'll see that they have an extreme amount of craving to want to obtain opiates. They'll feel frantic. They'll be calling the doctor and saying, I need my pills. And as a physician, I can tell you many times I'll get calls on weekends from people who will let me know that there's some reason why they ran out of their prescription. And so those are some of the symptoms that I would look for: mood changes, withdrawal symptoms, needing higher and higher doses just to feel comfortable.
And I guess it comes back to that, research and conclusion you came to where, it's the people are taking them and then they're left after that wear off, they're left with that kind of deficit feeling and the opposite feeling. And then it just comes a vicious cycle.
Exactly. Yeah, that's exactly right. Yes.
Wow. Now, as you mentioned, a lot of these current drug dealers are mixing fentanyl with other drugs. And as of 2021, about 75% of the drug overdose deaths in the US involved opioids. So what are some of the signs of an opioid or fentanyl overdose? And what should we do if it's either happening to us or someone we are with? And can fentanyl overdose be treated?
Yes. So if someone that you're with begins to act sluggish, begins to become unresponsive, that's a sign of being concerned. If their breathing slows down or they stop breathing, that becomes a medical emergency. Now, you may not know if it's related to opiates, fentanyl, or some other medicine or drug, but if you look at their pupils, if their pupils are small and pinprick, that's a sign of opiate overdose. Now, if that happens, certainly call 911 right away and get someone there to help. Now, hopefully, you have available a medicine called Narcan or naloxone. So that's just like that naltrexone stuff I talked about to help with the rats and their drinking and humans with their drinking. But it also helps block opiate receptors and can reverse overdoses. So that's really important. And it turns out naloxone has probably saved more lives in this epidemic, opioid epidemic, than any other intervention that we've had. In my state in Pennsylvania, for example, anyone can walk into a pharmacy and the secretary has put a prescription in for anyone that they can pick up naloxone. And they've made it so it's very easy to administer. You can give it as a nasal inhaler and wake someone up who's overdosing. Now, what we find, because fentanyl is so potent, sometimes it takes higher doses of naloxone to reverse that than we found when it was just heroin or other opiates. But you can still reverse it. You can save people's lives. Very important to do that.
Wow, that's amazing that there's this out there that can help. I feel like any child or anybody that's buying drugs right now needs to have one of those along with them, just in case.
Yeah, if you're concerned that a loved one may be having a problem with opioids, it's probably a good idea to have some naloxone around just in case.
Right. Now, let's get into more how to kind of reclaim our health and wellness from addiction. And your research, as you were mentioning at the top of the show, has led to many important discoveries in addiction treatment. And you're really at the cutting edge of new treatment discoveries. Now, you talk about their proven medications and also some new technologies that involve artificial intelligence called CBT and digital therapies. Can you share with us what some of these are?
Yeah, well, let me go through the history a little bit. That what I found was that when you add psychotherapy, psychosocial support to the medicines are very effective. And so for the opioid epidemic, we have some medicines that are very helpful in terms of helping people feel comfortable and reducing harm associated with using opiates. For example, there's methadone, which has been around for a while, and that's effective in reducing withdrawal symptoms and craving for opiates. Problem with methadone is you need to go to specialized clinics every day to pick up your methadone dose. So that's not practical for some people. More recently, there's a medicine called buprenorphine or Suboxone that people have heard about, most people have heard about, and that's also effective. And that half stimulates and half blocks the opiate receptors. So it can be useful for helping to take away withdrawal symptoms and also helping to block the effects of opiates later. And then the other medicine is naltrexone. So that also that blocks the opiate receptors. And there's a version of naltrexone in which you give it as an injection. So extended release naltrexone. So you come in and you get a shot once a month, and that's all very effective. So 3 different strategies in terms of medicines to help people. But what I find is that if you just use the medicine by itself, that doesn't seem to be very effective. It's important to combine it with some psychosocial support. And one of the things I did pretty early on was I designed a psychosocial treatment that healthcare providers could use. So you didn't need to have a fancy Ph.D. in psychology to use it. It was very easy to use, and even wrote a book about it. And what we found is in research that the people who are doing research studies loved it because it helped improve patient retention or subject retention. And in research studies, people who drop out really messes up your research study. And so it was applied there. And what we were finding is that we were really getting good results in helping people recover from alcohol addiction and opiate addiction. And one of the things that frustrated me was that people in the treatment community were not taking advantage of what we learned from our research. And so that's why in 2009, I set up the Volpicelli Center to be sort of a model of how you could use evidence-based treatments to help people. And so for the past 12 years, 13 years or so, we've been running a program where we've combined medicines with psychosocial support to help people with addictions, and it's worked very well. Now, when I tried to present that to other clinical programs, what I found was that the doctors who are using, say, Suboxone or buprenorphine said that, well, I agree, we should provide psychosocial support, but I'm not really qualified to do that. And when I refer people, my patients can't find a therapist to give them the psychosocial support. And so there is a huge lack of being able to integrate that with the medicine. And so I've talked with some companies about how we can deal with that. And one of the new waves of treatment is the notion of a digital therapeutic. And a digital therapeutic is sort of a digital therapist that you can access anytime. You can get an internet connection. And what they do is they provide CBT therapy, cognitive behavioral therapy, and they present it as modules to people so that people can learn CBT techniques in a safe environment that they can access in the middle of the night. And what the research has shown is that that has been helpful in a variety of settings to help people be engaged in treatment and stay in treatment. And so we're doing research now to see if the combination of a digital therapeutic called MODIA works well with our program using medication-assisted treatment to help people recover from opiate addiction.
Fascinating. Can you share a bit more about what MODIA is?
Yeah, so MODIA is a program where the computer program presents CBT therapy in modules. Now, what makes it unique is that when it presents a module to a person, it then asks the person questions like, did you understand that? Was this helpful for you? Do you want to go into more detail? And based on the response of the person using the digital therapeutic, the program then varies its approach in dealing with that person. So it has artificial intelligence built into it to help engage people. So, for example, I have some patients who use MODIA who say, well, I just want to get the basic facts and, that's all I need. And so the program then will present that to the person. And so the person gets what they need.
Right.
For someone else, they may want to go into a little bit more detail about it. They want to say, why is this? What are the statistics for this? And then the program can adapt and present that in more detail. And so it really engages people in the treatment. So it's more than just getting CBT therapy from reading a book. It really feels like you're talking with someone who's flexible and is going to address your needs.
Fascinating. And it's so important. I mean, knowledge is power, and especially when it comes to addiction. Understanding, like what you were just explaining at the top of the show, how addiction works, understanding the cycle of it. I mean, that makes a very big difference. And the points where you can kind of, like you were saying, if, when you're addicted to these pretzels, if you can, have that 20-minute period, if you can distract yourself for that 20 minutes, I mean, giving people tools like that along with the medication, I'm sure makes a big difference.
That's exactly right. As people really know what addiction is and how it affects them, then they're in a much better position to do something about it. I know many people are sort of ambivalent about coming into treatment. On the one hand, they see all the bad consequences of using drugs, but on the other hand, they see the good effects that the drugs have. They makes them feel better. But it's only when you can connect the dots and say, well, when you drink or when you use opiates now, a couple hours later, you're going to pay the price later. It's sort of like borrowing money from the bank. It may temporarily help relieve your discomfort, but you're going to have to pay that back later with interest. And when people begin to see how there are consequences associated with their drug use, they begin to get more on board with, well, I like to do something about it, but I'm afraid to do something because I don't want to go through withdrawal, or I don't want to not enjoy life anymore. And so you can show them an alternative that the medicines can help take away the withdrawal so it won't be so uncomfortable. And your life can be so much better if you apply some of these principles to help learn to manage stress and difficulties in relationships without using drugs.
Wow, that's such a powerful combination. That makes so much sense. Now, you mentioned you're the founder of the Volpicelli Center, which is the Addiction Recovery Center, as well as the Institute of Addiction Medicine. Can you kind of give us a little more of an overview on what your recovery center program entails? Like if someone were to, go there to deal with their addiction, what that would look like, and also what type of work are you doing at the Institute of Addiction Medicine?
Mm-hmm. Yeah, so our Volpicelli Center, the program is set up very much similar to the research studies that I did. So when people come in, they get a thorough psychosocial evaluation. So we see addiction as more than just if you're using drugs or not. It's more than just if your urine is positive for a drug. For us, recovery is about getting your life back. And so when we assess people when they first come in, we assess how they're doing psychologically. Do they have depression? Do they have anxiety? And if they have those issues, we design a program that's unique for them that addresses those issues. For some people, they have social issues in terms of difficulty with employment or difficulty with relationships. And for those individuals, we might add couples therapy or bring in a family member to help them. And for other people, they may have medical problems associated with drug use. And we also have physicians who work here who can address those issues. So we do a thorough evaluation when people first come in, and then we design a program that's specific for them. Now, typically it would involve first detoxing from opiates, and we have some medicines to help with that. And for many of our patients, they can detox in an outpatient setting. So you don't need to go away. You don't need to spend a month in a rehab center, that we can help people come off their opiates safely and without too much difficulty. Although with fentanyl, it's turning out to be a bigger challenge than it was for heroin. That coming off of fentanyl seems to be more severe. The withdrawal is more severe than coming off of heroin. Mm-hmm. And some of our patients have tried on their own to use medicines to come off fentanyl. For example, that buprenorphine, the Suboxone. And what they found is that the buprenorphine can actually bring on withdrawal as opposed to take away withdrawal. And so they're a little bit reluctant to use Suboxone to help them get off the fentanyl when they come to see us. But we talk about ways that we can use it in a controlled amount that works. So, and we have our special other medicines that we use to help make people feel comfortable. And for the most part, people feel pretty comfortable. So that's the first step, is to help people detox off the drug. Then the second is usually we combine some sort of medicine to help prevent a relapse. For people with alcohol, typically we'll recommend that extended release naltrexone. And for opiate dependent folks, we'll recommend either buprenorphine, or we'll recommend that extended release naltrexone, depending on their preference. And if they want to be completely abstinent from all opiates, then the extended release naltrexone is a better option. But for some people, their life is so disorganized at that point that they just want to feel a little bit better now, and maybe later down the road, they'll go to the Vivitrol. And so we add the medicine, but then we have people come in every week to talk to someone to help engage them in treatment and deal with issues that may be involved with either the medicine or dealing with life without using drugs. And what we find is that a very high percent of our folks who go through the program are successful. And so I'm really pleased. I'm in my office right now, and in this very spot, I see people come in who've been clean, they've been off opiates for years, and they bring in their spouse and sometimes their children. And for me, there's no more rewarding job in medicine than helping people who have addictions. I think it's an incredibly rewarding field, and it's great to see people recover.
Beautiful. And what I really appreciated by your entire explanation is really, I think a lot of people, including people that are addicted, to understand it's not just like a mental, I'm depressed or I have this, it's not a mental thing. It's actually a physiological
thing.
Yeah.
Well, it combines behavior and physiology, which is my goal from the beginning. I've always had that interest. And for me, understanding addiction medicine has combined all my interests. I think William Osler once said, if you know syphilis, you know all of medicine. Well, I say, if you know addiction, you know all of medicine, and a good part of psychology and sociology as well. So it integrates with all those areas. And so it's always interesting for me.
Now, you mentioned at the top of the show, kind of touched on this, kind of zooming out to a macro view of this opioid crisis that we're having in the US. What would be some ideas, how do we tackle this issue, and how do we, help heal this issue and decrease crazy percentages of fentanyl and opioid addiction and overdoses?
Yeah, I mean, it's unacceptable that 100,000 people die from opiate overdoses. That's terrible. And the alcohol situation is not much better. I think about 100,000 people died from alcohol-related diseases as well. So it's really not a very good state of affairs. And so the reason I set up the Volpicelli Center was to show that you can have a real live functioning program, not part of University of Pennsylvania, which is where I was working before that, in an academic setting, but in a real life program that successfully can treat folks. But what I'm still frustrated with, and that's why I'm doing the podcast now, is to help inform people that there's strategies to get better, and we need to do a better job, and we need to hold our treatment programs more accountable. And so the mission for the Institute is to help teach clinicians and talk to the general public about options available for treatment that go to a treatment program that integrates medicine and psychosocial support. That's going to give you your best chance for recovery. We need to convince insurance companies to pay for such a program. I can tell you some of the challenges with that. We need to convince the federal government to address these issues. I find that the war on drugs is not a very effective strategy. So just trying to limit access hasn't worked very well. But if you can reduce demand by treating addictions and having people understand what addictions are, I think you go a long way. A very high percent of folks, when they initially come into treatment, they feel really ashamed about their addiction. They deny that they have a problem, and they feel that there's something fundamentally wrong with them. They have some defect in their character, or they're a bad person because they have addiction. And we have to educate the general public that that's not the case, that I can have an addiction to my little pretzel things. Maybe it doesn't have as severe consequences, but the principle of it is the same. And for people who have addictions to opiates, it's an interaction between their particular biology and the drug. And by not understanding how the effects when the drug wears off can produce that addictive cycle, that's what gets people in trouble. And we can block that cycle now. We can help people feel comfortable going through withdrawal, and with the combination of medicines and psychosocial support, block them from getting back on that addictive cycle. So we can do a much better job. So that's the mission of the Institute, and that's why I'm doing these podcasts.
Beautiful. There's a lot of hope for everybody. And you talk about shame. I think that's a big part of the healing. That's not always as tangible. It's part of the whole process of healing. And you mentioned that too. Not every recovery center is created equal. Would you say that? I mean, how many of them would you say, compared to how many of them don't kind of use this integrated holistic process?
Yeah, so even though people will say on their website that they use an integrated approach, what I find is when I talk to people who are running the programs, or actually you're doing the treatment there, that usually it isn't very integrated, that people have a certain philosophy. So some programs are more abstinence oriented, that they believe that the only way to recover is to completely abstain from drugs, all drugs. And that may include even drugs that could help people stay away from that addictive cycle, so that they're not very enthusiastic about using buprenorphine or even the naltrexone, and they don't promote it very much in their programs. I have many folks who've gone away for 28 days into luxury rehab programs, and while they're in the program, they're away from the people who could engage them in using drugs, and they feel comfortable. They don't have very much craving. And then when they leave the program, they immediately go back into the old environment, and a very high percent of them relapse quickly. And while they were in that rehab program, they had all kinds of various kinds of therapies, including going out to look at the dolphins and pet the horses and all that. But no one talked to them about a medicine that could help break that addictive cycle.
Right.
That if they slipped up, they wouldn't get high. It would block the euphoria. And that's not acceptable. I don't think that's acceptable. And there's other programs where doctors set up a program where they can do well financially by just writing for buprenorphine and maybe a couple other medicines in there. And maybe the people will come back because maybe they sell a couple of their pills, and there's no psychosocial support.
Right.
They just continue in the addictive cycle where they're still using drugs in not an appropriate way. Their life is still not getting better. And some of those folks then stop their buprenorphine for a while, and then they may find that they use a little bit of that fentanyl stuff, and they've overdosed and died. So you need to have a comprehensive program, and we need to convince employers, insurance companies that they need to pay for that, because the cost for addictions is not just in the profound effects that it has on the individual and the family and society, but it has a huge financial cost in terms of the healthcare system. It turns out that people who have addictions not only cost in terms of their addiction, but the treatment of their other medical conditions is also much higher. So a person who has addiction and high blood pressure, treating their high blood pressure is much higher. People have diabetes and addiction, their cost of treatment is much higher. So it really would be in the best interest for insurance companies to aggressively go after treating addictions and mental health for that matter. And so in terms of these macro issues, that's what I'm trying to do with the Institute. And so I've tried talking with insurance companies and the government and wherever else people will listen to me to try and get them to understand that a treatment is effective and can work, but it needs to be a treatment that combines the best of what we've learned from research, right, and to be applied clinically.
So it sounds like from what you said, we have treatment centers that are doing one or the other. They're either giving the medication, they're not doing much of the, other support, or they're giving all this, support and no medication.
It's like there's two silos, right, and the two silos don't talk to each other
There's
very
like
much.
Belief systems around it.
Exactly. And the one silo believes that you need to just reduce harm by giving these medicines. And if they are dependent on methadone, then that's fine. At least they're not using fentanyl or heroin. So it reduces their harm. So that's a good acceptable treatment. And then the other group says, no, that's not really treatment. The only treatment is abstinence, that you need to stay away from that addictive cycle by never using. And for some people, they get relief by doing the abstinence approach or by being on something like methadone for the rest of their life. But for the large majority of people, neither of those options sounds very attractive. And there is another approach in which people initially might go on a medicine to take away withdrawal, but over time we can gradually taper it so that they feel comfortable and also address issues in their lives. That's what recovery is all about. Right.
Absolutely. And a question around these medications, and you kind of just touched on it. Is this, for an addict and they are doing this therapy and these medications that are actually helping the withdrawals, what's kind of the time frame that they would need to stay on, to help, how long physiologically do our bodies kind of hang on to these, reactions?
Yeah. So again, it varies for each individual, but for something like alcohol, usually we can get people safely off alcohol in about 3 to 5 days. Now,
Mm,
some people will continue to have protracted alcohol withdrawal symptoms, and that can last for a couple of months. And there's different classes of medicines that can help with that a bit too. For opiate addiction, if we are going to go from taking opiates to being completely off opiates, if you do it very quickly, you can do it in a matter of 6, 7 days.
mm,
Um, but for many people, rather than to get completely absent from opiates, what they would rather do is go from street drugs to something like buprenorphine, which can be effective in helping to reduce some of the withdrawal. And again, if you use it correctly for the folks with fentanyl, if you start with a low dose, you can safely get people off the fentanyl. And then we keep people on buprenorphine for a period of time. For some people, they want to get off right away, and they might do that in the course of a month or so. For some people, they need the period where they can just sort of reflect where they are with their life and get their act together a little bit. And so it's fine for them to stay on buprenorphine for 6 months or a year and then gradually taper at that point. So it depends on the individual, but we always have in mind the goal that to be to break that addictive cycle, to be away from drugs, and to have a healthy, functioning life. And people recover. A lot of times, people, when they think of addiction, they think it's just a chronic disorder in which it's impossible to recover from. But that's not the case. I've seen people recover and go through life where they don't think about drugs anymore. I have many patients who, I have a patient right now who's going through a very difficult time. He's broken up with his girlfriend. And in the past, he would immediately use when something like that would occur. But he tells me now he has no interest in using. He's actually doing a lot of healthy things right now. He's going to the gym. He's getting buff. He's working out. He's feeling better about himself, but he's still really sad that he misses his girlfriend. And he wonders if he'll ever get another girlfriend again. But we're dealing with that with talking and by him doing healthy behaviors. He's eating healthy, getting rest. He's doing a lot of healthy things instead of doing the unhealthy things that he was doing before. For me, that's as important as if his the urine showed that he had opiates in his urine.
right. Now, with everything you said about, the detrimental effects of opioids, do you think that this should not be something prescribed as a painkiller? Are there other alternatives that we should just cut out opioid prescriptions altogether, since they have such a
Yeah, that's a really a great question. And I've been around long enough that I've seen the pendulum swing both ways.
Mm,
When I first got into medicine, there was a report that the Institute of Medicine came up with to say that doctors were underprescribing opiates for pain, that people were walking around and they produced a tremendous amount of disability and suffering that was unnecessary. And so we had this class of compounds that could help relieve their pain, and we should be more aggressive with using them. I know it sounds crazy now, but that was absolutely the case. Now, what happened was when used properly, it did work. But, and this gets a little controversial, there is some pressure from some pharmaceutical companies to use a compound that was supposed to be able to be used twice a day. Normally, morphine, you'd have to use it 3 or 4 times a day. So there's a new formulation that you only had to use twice a day. But what happened was it wasn't a very useful twice a day medicine because people would begin to go through withdrawal, about 6 hours in instead of 12 hours when they're scheduled for the next dose. And so guess what happens when people are in withdrawal and then you give them the next dose and they feel better? It's exactly the conditions that one would need to set up addiction. So people would say, I really need that next dose. It's wearing off. Well, you're not supposed to get it for another 4 hours. And then you feel awful. Then they would get the next dose and say, oh, thank God, I feel better.
mm,
And then the patients would say, I need more of it. And guess what? The pharmaceutical company would say, you know what? If people are doing that, that's not really addiction. I know it looks just like addiction, but it's not really addiction. They called it pseudo addiction. So you can Google it. It's a pseudo addiction, not real addiction, because it's being prescribed by a doctor and they're not getting it on the street.
Oh, okay.
So the doctors would say, well, how do I treat pseudo addiction? And then we were taught, just increase the dose. So we, in our ignorance, did exactly the wrong thing to help people with pain. We cause them to associate the way to take away withdrawal symptoms is by redosing. And if you have to keep increasing the dose, that's perfectly fine.
Right.
Now, so that was, we really then went the other direction where we prescribed opiates way too much. And as you pointed out, in the United States, we use a lot more opiates than any other country. And, to some extent, the patients were happy. They would come back and say, "Thank you, doctor, and you're giving me all these good opiates." But the outcome wasn't very much better. People were still not very functional. They still weren't feeling better. Now, having said that, I have to point out that there are some people, I even have one person in my practice who's been with me for, 30 years now. She has chronic pain. And way back in the day, I gave her a low dose methadone. And for 30 years, she's continued on that very low dose. She hasn't increased it. She hasn't decreased it. And I tried to switch her over to another one. And the insurance company said, "We can't switch to that other medicine because it's too expensive. The methadone is cheap. Keep her on that." So she's doing fine. She's not out of control with it. She doesn't show that tendency where she needs more and more of it. So that can occur. But there are cases where the use got out of control and people wound up getting addicted. And then what would happen is the pain doctor would say, "Oh my goodness, this is terrible. I see that you saw this other doctor over here to get a prescription filled. I'm dropping you from the practice." So they would be cut off. And then that's when the patients would frantically call me and say, "I need treatment for my addiction, or I need to find a pain doctor who's going to write for the medicines."
Right. Or they go to the streets.
Or they go to the street. Exactly right. And going to the streets can have fatal consequences, especially right now. So not a good strategy. So people who say never use opiates, that's, I think, taking the pendulum the other extreme, that there are people who do need opiates, particularly if it's used properly. And for me, if you have a chronic pain condition, normally I would use opiates just under very extreme conditions where the pain is particularly high. I wouldn't use them chronically over time because that's when the body has a chance to adapt to it. And so use it just sparingly as needed. For people who have acute pain, maybe you're having an operation or whatever, it's fine. Use the opiates. And I have many patients who were on opiates and the doctor just stopped them and they felt kind of crappy afterwards, but they didn't associate that crappiness with the need to use more opiates. So they didn't go into addiction. But if you use it in a smart way, where people don't go through bad withdrawal and then redose on the opiate, you're not going to create addiction. So we just need to be smart about how we use our medicines. I often remark that addiction medicine is not rocket science. It's pretty simple once you understand the principles involved. And we need to do a much better job of how to use the medicines appropriately, but not just make a firm rule, "I'll never use this," or "I'll never use that," or use too much of this or too much of that. No, there's a way to do it in a smart way.
Right. And are there alternative painkillers to opiates that are less addictive or kind of, I guess, quote unquote, safer as far as kind of getting into addiction?
Oh my goodness, yes. So, I work with a lot of pain patients, and there's a variety of medicines that can be helpful for reducing pain. For example, I have patients who their pain is worse when they're angry. And so we deal with that issue and their pain is better. And there are medicines like certain SNRIs that can help reduce pain. There are medicines that can help reduce that nervous, where the nerves are a little too sensitive. So you can reduce some of the sensitivity of the nerves. There are anti-seizure medicines. So there's a variety of approaches to help people with pain, including behavioral approaches, stress reduction techniques. Meditation can be helpful. Exercise can be helpful. A good, healthy lifestyle is a good, effective way of dealing with pain. And sometimes you have the pain, it's your body's signal that something is wrong. And it's important to acknowledge that signal. It's sort of like an alarm clock that it's ringing in the background. And until you recognize that it's ringing, go over and address it, it's going to keep ringing. So you have the pain, you need to address what's causing the pain, not ignore it. And if you realize that this is the cause of the pain and it's nothing serious, a lot of times the same sensation can feel completely different. I remember one time I had I thought I broke a ligament or whatever in my shoulder. I went to see a doctor, and then my shoulder was hurting terribly. And then he felt it, and he said, he just strained something. It's okay. I'll go away in a few days. It went away by the end of the visit, because the pain, now I understood what was causing it and what the course of it was going to be. And I felt so much better.
Right.
So pain is an important signal that you need to address. And there's a variety of ways to address it, some of them medically and some of them behaviorally.
Absolutely. And yeah, like you said, because it's a signal, it's not always the best thing to do just to cover it with a painkiller. It's better to, phase it square and be like, all right, do I need to make a lifestyle change? That's why I love combining kind of Eastern and Western medicine, meditation or lifestyle, or, there's so many other different modalities as well. But I think the great thing is, from what you just said, is there are other options that we can ask. If we absolutely need a painkiller, we could ask our doctors for a non-opiate painkiller.
Yeah, exactly. And to be smart about it.
Yeah,
that's all.
Absolutely. Well, thank you so much. This was so informative. What's the best way to contact you if someone watching or listening would like to find out more about your Addiction Recovery Center? Do you have any other resources available around addiction and recovery?
Sure. Yeah. So you can go to the website, volpicellicenter.com. Or if you want to email me, you can just send me an email at volpicelli.j@gmail.com. But I'd be happy to talk to folks. That's again, one of my missions is to help get word out that there's good, effective treatments, and we can do a better job of helping folks recover.
Absolutely. And you also have a book. I'll post a link to that below.
I have a couple of books. I have a book called Recovery Options, and another book called Integrating Medicines with Psychosocial Treatments, the Brenda Approach.
Okay.
So people can look at Amazon and Google my name and see my books.
We'll post that below for everybody too. So with your recovery center, do people have to be local, or do you do kind of, Zoom treatments, or can this be like a tele appointment, or does it have?
Yeah, so we've done both now. So during the pandemic, we started doing more telemedicine, and so we have a hybrid program now. So we like people to come in and give us urine drug screen. So we like to monitor their progress. But, if that's not possible, we can do them remotely. So we have the flexibility to go either way now.
Oh, wonderful. That's great for everybody else that's not in your area. Well, I'll post a link below to your website and your books. And I'm also going to post a link below to a substance abuse hotline and some other great resources that everybody can check out. But before we wrap it up today, do you have any final thoughts or words for those who are currently dealing with addiction or have a loved one dealing with it?
Yeah. The message is that there's hope. There's good news out there, and there's hope that people can get better. So even if someone's had a hard time recovering in the past, to get them in a good quality program. And I would say that involves integrating medicines with psychosocial treatment. And there's a really good chance that people can get better. Try not to judge folks. That's not going to help them. But to be open to new ideas, to be curious for new ideas and effective treatments. We're constantly learning new strategies, new approaches, and look at addiction from that perspective.
Beautiful. Thank you for all the work you're doing. And thank you so much for joining me today. This information is so important around synthetic opioids and fentanyl, with everything going on right now, as well as giving us some great information on healing and recovering and all your important work and research. So thank you so much for everything you're doing.
Thank you very much.
And like Dr. Volpicelli said, if you suspect someone has overdosed, the most important step you can take is to call 911 so they can receive medical attention immediately. And remember, knowledge is power. The more you understand about your body, the better you're able to stay healthy and prevent disease. And a quick reminder, I'm not your doctor, so please don't take this as medical advice. If you have specific questions about your healthcare, feel free to reach out to your practitioner. And if you like this video, please like and share it with others. This information could really help someone you may know. Also, hit that subscribe button and the little bell to be sure you don't miss out on our future shows. And join us next Wednesday for the next episode of Discovering True Health.